Hi, everyone, and thank you for joining today's virtual educational program with Cancer Support Community Los Angeles. I am Edlyn Rodarte, and I am the program coordinator with CSELA. I'm excited to welcome you to this week's webinar titled Breast Health, the Importance of Knowing Your Breast. During today's webinar, Tara Kays will cover up-to-date screening guidelines of breast cancer, discuss who is considered high risk, and explain what to do if you feel a lump or have a new unusual symptom. Tara will highlight the importance of getting your annual mammogram and define what is meant by dense breast. Knowing your breast and the type of symptoms you should look out for are the first steps of being proactive in your preventative care against breast cancer. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about services or watch past webinars, please visit our website at www.cancersupportla.org. Before I introduce today's speaker, please note that we cannot see or hear you. Your video and microphone are automatically disabled for this webinar. We will not be monitoring the chat room, but you may enter your questions into the Q&A feature at any time. Give me one moment, I am sorry. Questions will be answered at the end of the presentation. We may not be able to get to all your questions today, but our presenters invited to share their contact information at the end of the presentation. Without further ado, I'd like to welcome today's speaker. Tara Jean Ower Kays is a breast specialist in the breast health clinic at the Margie Petersen Breast Center. Her mother inspired her to pursue a nursing career after sharing the rewarding aspects of the profession. Now specializing in breast care, she incorporates her past knowledge and interest in helping women succeed and grow through difficult medical situations. Tara has been with the Margie Petersen Breast Center for over 4 years and helped start and runs the Breast Health Clinic. The Breast Health Clinic provides quick access care to patients that develop any new breast symptoms and allows for expedited consultation, imaging, and if necessary, biopsy. Recently, Tara has helped the clinic expand out to the Burbank area so more women can get the excellent care they deserve. Tara specializes in benign disease, high-risk breast cancer screenings, and after breast cancer surveillance. Welcome, Tara. Thank you so much for joining us today.
Thank you for having me.
The floor is all yours.
Thanks. Okay, let me share my screen. Share. All right, so we will begin. My name is Tara Jean Ower. Some people might know me as Tara Jean Kays, but I did recently get married. So I'm slowly transitioning over to Ower, but that is why you have the longest name ever. But I am a breast health specialist. I work at St. John's Cancer Institute and the Margie Petersen Breast Center at Providence St. John's Health Center in Santa Monica. I've been there for over 4 years, and I specialize mostly in breast health. So we will kind of go over a few things today. Like said before, a couple of things we'll go over is the, breast cancer screening guidelines. Those can be a little bit confusing, so hopefully I can break it down for you. review of the different breast imaging types, who is high risk, symptoms to look out for, and what do you do if you notice a symptom. So here to just kind of start is myths about your breast. So these are things that I hear actually pretty often, and a lot of them aren't true. And so it's kind of going through and breaking down what do you hear, on a daily from just different rumors or whatnot, and what is true. So breast pain means you have breast cancer. No, it does not. Breast pain, we actually like it in the breast cancer world. We kind of hate saying that, but it usually means it's not breast cancer. It usually means it's something else. So it should give you a little peace of mind that most women have breast pain in their lifetime, whether it be hormonal or a cyst or a fibroadenoma, usually doesn't mean it's breast cancer. Is it something that should still be investigated and evaluated? Yes, of course. But for the most part, it's nothing. My grandmother had breast cancer, so I'm at higher risk for developing breast cancer. This isn't true either. Unfortunately, a lot of our grandmothers have had breast cancer. So those that are higher risk are usually first-degree relatives. And we'll go over that a lot more later. I have a history of breast cysts, so I'm at higher risk of developing breast cancer. Breast cysts are super normal as well. They're just pockets of fluid. They're basically, almost in a very crude, weird way, pimples in your breast, right? They're just pockets of fluid, and they're purely hormonal. So most people get them. They kind of come when you ovulate, and they can get a little bit bigger, and then they go away during your cycle, and they fluctuate like that. But they don't turn into cancer, and they don't put you at higher risk for cancer. Can they be painful? Absolutely. So a lot of the times people will come in more because it's pain, but it's absolutely nothing that's going to cause breast cancer. I will have to have a mastectomy if I'm diagnosed with breast cancer. Nope, not really anymore. Is that an option? Absolutely. But I'll go into a little bit more about what my surgeons, the two that I work with at St. John's, do, something called oncoplastic surgery. Mammograms have too much radiation, so it's okay to skip them and just get an ultrasound. Absolutely not. And we will go into more detail on that one. Does it have radiation? Yes. Is it okay to skip them? No way. I should not have a needle biopsy because it can track cancer cells to a different part of my breast. While this can be true with other cancers, it is not true with the breast. We have never found any research or any kind of evidence that shows that when we do a needle biopsy that we're going to find cancer somewhere else. So that's not true either. And then here's another one. Only women who are breastfeeding can develop mastitis. Not true either. You can actually develop mastitis at any point in your life. It's just kind of like an infection of your breast, right? Your breast is also skin. So your skin can get infected with bacteria. So you can get, what mastitis means is a breast infection. So you can get it at any point. People who are breastfeeding are more susceptible to it, but it doesn't mean that they're the only ones who get it. So if you ever got mastitis in your life, you know where to go, but also don't be really scared because at the same time, it can happen outside of breastfeeding. Okay. These are the breast screening recommendations. This picture kind of just shows how it's kind of all over the place, right? If you actually go in and look, there's a million different recommendations. It can be super confusing. We have the U.S. Preventive Task Force, American Cancer Society, American College of OB/GYN, and thus far all saying different things, right? So it gets super, super confusing. We'll go more into that and what you're supposed to do, but the benefits of screening the mammogram show that there's a huge mortality reduction with screening. And these are the different age groups you guys can kind of read, but this is just research showing the benefit of screening, that, the absolute mortality reductions or deaths prevented with screening was 4 per 10,000 women over 10 years, in ages 39 through 49. Well, it doesn't seem that much. It is, right? We'll take 4. And so on and so forth. The harm, right, of screening mammograms. So some of the harm is that you get false positive rates, and those are usually within the ages of 40 to 49, and we'll kind of explain why. And then you can have some overdiagnosis, and false positive rates can then cause anxiety. But ultimately, we need to do the risk versus benefit. Benefit is there's a mortality reduction. We're finding cancer earlier, and we're, saving people from dying from it. When you find it earlier, there's a reduced cancer stage at diagnosis, which means you have reduced treatments. The risks, there's a false positive rate for the younger 40 to 49-year-olds. There's anxiety, there's overdiagnosis and overtreatment, but the risks outweigh the benefits. Mammograms are still standard of practice. Basically, it uses compression and X-ray technology to image your breast. The radiation question we had before, it does have radiation, but it is the same amount of radiation you would get naturally over 7 weeks, or just getting on a plane in LAX and flying to New York. We don't actually think about it when you get on an airplane, you just get on an airplane, but you're getting that much radiation. Once again, we're looking at it as risk versus benefit, right? And the risk of the radiation is better than the, wait, that's wrong. The radiation risk is worth finding the cancer earlier. So why are mammograms the standard of care? One, because they look at the breast tissue. And I'll show you a better picture in a little bit, but they're the only way we can see something called breast calcifications. Breast calcifications are basically calcium deposits. And on your mammogram, they look like little white dots. When they're scattered all over your mammogram and they're little white dots all over, we know they're totally normal, they're benign, they're nothing. Everyone gets them as they age. But sometimes they can be in a cluster or a line, or they're new. That's why you get your annual mammogram every year, because we're looking for these small changes. And that's how we can find something called ductal carcinoma in situ, or stage 1 breast cancer. So when it's at its earliest. Breastfeeding women and pregnant women should not have a screening mammogram. If, say, someone is breastfeeding or pregnant and they have an actual mass or a lump or something to look at, then we can use a mammogram, but we don't routinely do screening mammograms on breastfeeding and pregnant women. I'm sure, in your life, you've kind of noticed different things. There are 2 types of mammograms. There's a screening mammogram, and that's what you get yearly, right? And that is just a big picture of your breasts, right? It's just a couple images to take a big picture and see if anything's changed. If something has changed and there's something they want to look at, then you'll get a call back, and then you'll get a diagnostic mammogram. And that's only performed when we're looking at something specifically. This has kind of been a bigger issue, obviously, since COVID. And usually you guys will get asked this when you're scheduling your mammogram. But they'll ask kind of, when did you last get your COVID vaccine, or any kind of vaccine like shingles, pneumonia. We've seen this for a long time before the COVID vaccine came out with shingles and pneumonia. It's just that, a vaccine, because it's causing all the antibodies and your body to react, it causes your lymph nodes to get bigger, right? Because it's working. So when you go in right after you've gotten it, your lymph nodes are bigger. So that can kind of, if they're bigger and we don't know you've had the COVID vaccine, that can lead to more testing, overdiagnosis, overtreatment, because we're going to think, oh, what's going on with her lymph nodes? And we're going to say, okay, maybe we need to bring her back, or biopsy or whatnot. So once we kind of saw, oh, this is happening, now we say you can either do 1 day before your first vaccine or 2 weeks after your second vaccine. That way, and also they'll ask you now. And if we kind of know, then we kind of know, oh, okay, this is what's happening. So this has been a big topic in the news lately, which is great. Breast density, what does it mean? So first, there are 4 types of densities. And these are all the different pictures. So if you look at picture A, that one is called fatty. See how it's mostly black? That's all fatty tissue. And then you go into B, that's scattered, that's kind of average. That whiteness is your density. So that is your fibrous tissue or your connective tissue. It's what gives your breasts form. So basically, it's kind of what makes them round and perky. So that whiteness as your density, and as you can see from A to D, that whiteness is more prevalent. So there's less black, which in A is that fatty tissue, and more white in D. So that means it's really, really dense. Most people lie between B and C, scattered fibroglandulous tissue and heterogeneously dense. When we're talking about really extremely dense people, we're talking about D, and that is not the average person. Why does this matter? It matters because these are actual images of a mammogram, right? So what I was talking about before is we're looking for tiny white dots. We're looking for breast calcifications. And so when it's more white, it's harder to see those little white dots, right? Whereas when in A, where it's like more black and fatty, you could see those little white dots a lot easier. So that's why they're always telling you. Since April 1st, 2013, the state of California has always had a law that said that your providers have to tell you your density. What is now on the news is that now it's becoming federal. So while California has been doing this since 2013, the rest of the states are catching up. So for everyone that lives in California, you've already been having this done. So don't worry about it. Nothing's really changed. It's just that now it's more on a federal level, and the rest of the states that weren't doing it and weren't telling people their density now have to. There are also two types of mammograms, other than the screening and diagnostic. There's 2D mammogram and 3D or tomosynthesis. So going back to the density, why this really mattered. We used to do 2D mammograms. 2D mammograms were only just X-ray pictures, just like you get a chest X-ray, just lots of X-ray pictures. Now, most imaging centers do 3D mammogram. And if you're not getting a 3D mammogram, you can absolutely ask for one, and you should, because it takes a big 3D picture and gives a big picture with a lot more slices, and you can see through the density way better. So that issue with the density, it's still an issue, but it's not as big of an issue if you're doing 3D, because you can see through it so much better. See how in the 2D mammogram, you can't see that little mass there, right? It's too dense. But in that 3D mammogram, you can see through it a lot better. So if you get anything out of this at all, is make sure you're having a 3D mammogram tomosynthesis. Always. There's no reason to do a 2D mammogram anymore. These are the breast calcifications I was talking about. And remember, it's only seen on mammograms. It's not seen on ultrasounds or MRIs or anything else. So that is actually the main reason you get a mammogram every single year, is because we are looking for these tiny little white dots. See them in the first picture? They're really, really tiny. But, you know, people can have normal, benign breast calcifications, and they'd be scattered all throughout the breast. But as you can see, these ones are kind of in a little bit of a cluster. And there's a couple of different examples over on the other side of the differences that it can kind of look. So everyone gets their imaging report, right? You kind of get your report in either MyChart or whatever company you guys use. And this is just a little cheat sheet on how do you read this? What does it mean when you see a BI-RADS 0, a BI-RADS 1? So basically, you know, if it's BI-RADS 0, all that means is that you've had imaging somewhere else. It means two things. You've had imaging somewhere else, and they need to get that imaging to compare it to the imaging you had. So that would be my other little tidbit, along with, if you're not having 3D mammograms, get 3D mammograms. My other tidbit would be, don't jump to different places. Pick a place and stay there. People get lost, and that's how things get missed. because it's always better to have the same radiologist reading your images, because they can look back on multiple years and say, oh, this wasn't here before. This was here before. Oh, this looks different. But when you're kind of picking up the pieces from all the different places, it gets a little bit confusing. So it either means they need to get the old imaging, or it means you've had a screening mammogram and they're going to ask you for a diagnostic mammogram, which means they're going to look a little deeper at an area. BI-RADS 1 just means it's fine. It's normal. BI-RADS 2 means there's a finding, but it looks super benign. It doesn't look like anything. BI-RADS 3 means there's a finding. It looks very benign, non-cancerous, but they want to watch it for a while. This is pretty normal. So if this ever happens to you, don't freak out. BI-RADS 3 is, a lot of what I see. So it's probably benign. We usually, when we see a new thing and it looks really benign, and what I mean by that is when you look at an ultrasound or a mammogram, you can kind of tell on the imaging, okay, if something's benign, non-cancerous, it looks very symmetrical. It looks very smooth. It doesn't have these abnormal, like mountain looking features. So the radiologist can say, you know what, I think this is benign. This is a little complicated cyst. This is a little fibroadenoma. It looks really smooth. It looks really symmetrical. But they kind of get an option. How much do they think this looks benign? When they're pretty sure it's benign, they will then say, come back in 6 months. What they're looking for is something called stability. So it's basically showing, hey, this hasn't grown in 6 months. Well, cancer doesn't not grow, right? Cancer always grows. It just keeps growing. Whereas something benign won't. So they know that there's this 6-month sweet period. I know it kind of sounds like a long time, but it's not. Is that we know in 6 months, it will either have enough time that something's going to happen, something's going to grow, but it's still not long enough that would ever hurt you. So it would never be long enough that it would grow too much that it would ever hurt you. So that's why they say, okay, it's probably benign, but bring you back in 6 months. Let's take another look at it, make sure it didn't grow. And that's why they're looking for stability. The other option is BI-RADS 4 and 5. That's where it looks a little bit suspicious. Let's biopsy. Well, we can look at a mammogram, ultrasound, MRI, and we can say, hey, it looks really benign to me, or, oh, it looks really suspicious. But the way we have to find out is always a biopsy. We have to get the tissue to confirm what it is, no matter what. And then BI-RADS 6, that means that we know it's cancer and that the biopsy's already been done on it. This image on the other side, is just kind of like a no for you guys when you're reading your report. We look at your breast like a clock. So 12, 3, 6, and 9. So when you're reading something and they're saying, okay, on your, left breast at 3 o'clock, there's a benign looking breast cyst, then you kind of know the area that they're looking in. This is all Where's Waldo. They're kind of like, this is almost like your mammogram, and they're looking, lots of different things. But so according to the American Cancer Society, 10% of women that have a mammogram will be called back. It's a good amount of people. Out of those 10%, 8 to 10% of those women will need a biopsy. 80% of those biopsies done will be benign. So only less percent of the 10% that were called back will get diagnosed with breast cancer. These are kind of the main different utilisms for imaging, right? We have MRI, ultrasound, ABIS. ABIS is the automated breast ultrasound, sonosine, and thermography, and we'll kind of just go over the other ones. These are always in addition to a mammogram, right? Because mammogram is the only way we can see those breast calcifications, which is the only way we can find DCIS at its smallest form. So MRIs are not used for screening. They're used in addition. Most of the time, we offer our MRIs to our high-risk patients. And that's usually if they have an increased risk of breast cancer because they have a family history of that first degree, right? So say my mom had breast cancer, then that'd be my first degree relative, or my sister, my dad, my brother. Then I'm at increased risk. Or if they have known genetic mutations such as BRCA1, BRCA2, there's also a million others like PALB, CHEK, ATM. But then they're offered, in addition to the mammogram, an MRI. And what they usually do is mammogram, 6 months later, MRI, 6 months later, mammogram. And we tend to start that 10 years before the youngest first degree relative that had breast cancer. So if your youngest first degree relative had breast cancer at 50, say, then we'd start your, if you'd start you at 40, and we do mammogram 6 months later, MRI 6 months later, mammogram. The other reason we use MRI is for, staging breast cancer. So if we find breast cancer on a mammogram or ultrasound and we want to stage it, make sure that the lymph nodes look good, make sure there's no other tumors in the body, then we'll send you for a MRI. Another time we use MRI is, say you have a palpable mass. I can feel it, you can feel it, but it's not showing up on mammogram and it's not showing up on ultrasound. Then at that point, we can send you for an MRI to see if we can see it by MRI. That way we can biopsy it by MRI. So those are kind of like the main reasons we see it. We do MRIs. There is some talk of, if you go back, sorry, gotta go all the way back, that extremely dense, sometimes we can do MRIs on them. That just depends on a person's insurance, unfortunately, and if they'll cover it. But it is recommended that extremely dense where you really can't see through it. But remember, most people lay in that B and C area of heterogeneously dense or scattered. It's more rare to see the extremely dense. All right, let's keep going. MRI doesn't have radiation. It's a big magnet. So sometimes people aren't eligible because they have metal in their body. However, you do have to have contrast for a breast MRI. We can't see anything without it in the breast MRI because basically what we're looking for is blood flow. We know that cancer has to get blood flow, right? And so we're looking to see if anything enhances and if there's any blood flow. Another thing, even if you're high risk and you're on that schedule of doing mammograms 6 months later, MRI 6 months later, mammograms, and you get pregnant or breastfeeding, we can't do MRIs as screenings either. Ultrasound. So ultrasound is not used for screening for breast cancer. It's used in addition to mammogram as well. They're basically to look at another area of concern that's seen on a mammogram. A mammogram can kind of look at the breast tissue and they can see a lot, right? And you can see, oh, there's something here. And ultrasound looks deeper at it and says, okay, give me the characteristics of it. Is this solid? Is this fluid? Is this symmetrical? Is this abnormal shape? And kind of gives you more information. So like what we're looking at right here, it kind of, look how this is benign. This is very symmetrical. It looks very much like a circle or an oval. It's dark inside, so it's more probably fluid. So when it's fluid, we know it's a cyst, right? And from way back before, we know breast cysts can't hurt you. They don't turn into cancer. They don't put you at higher risk for cancer. They're just purely hormonal. Most people get them, but they can be very painful. Ultrasound cannot see breast calcifications, and they use sound waves, so no radiation either. Ultrasounds are the main choice of modality for imaging for women under 40. So say a 20-year-old came in and they felt a mass. We're actually going to go straight to ultrasound because we feel something, we want to know the characteristics of it, and it's probably something that's more hormonal, like a cyst, or something like a fibroadenoma. Fibroadenomas are basically, you have fibrous tissue in your breast, right? That density, and you have fatty tissue in your breast. And that fibrous tissue clumped together and formed a mass. It's non-cancerous. It doesn't turn into cancer. It doesn't put you at high risk, nothing like that. Whole breast ultrasound is not used for screening either. It is used in addition to a mammogram. It is a screening, right? It's a big picture of your breasts. It's a big ultrasound. So while this ultrasound is more, okay, we're looking at an exact spot and seeing what exactly is going on. The whole breast is a big, almost like a big movie. So we can see your whole breast. So this is really good when you're younger. Most of my patients that are, under 40 and maybe high risk or whatever reason they're starting early, they're getting mammogram and an ultrasound. For that reason is because they probably have more hormonal things like a cyst, right? They're going to be a little denser. And so that ultrasound is another look at it. Thermography, this is another big one. This one, there's no randomized clinical trials of thermography to find out how well it detects breast cancer. Thermography is basically uses a special camera to sense heat that's supposed to show tumors. This is not something we recommend, at least in our clinic, for our patients because it just doesn't have enough evidence to support the use for breast cancer screening. But it is a question we get asked about a lot. So technically right now, we don't recommend this. So imaging breakdown. Screening for breast cancer would be a mammogram, 3D if possible. And the recommendation is always to start at age 40. Sorry, I think I skipped that way back one, but it'll come back. A recommended age is always to start at 40. So we always go off the American Cancer Society. And that says that women start mammograms at 40. That's as simple as it can be. You're 40, you start your mammograms and you do them annually. And unlike some of the other ones that have an end, we don't actually recommend an end. It depends on, kind of the lifestyle of the person. If we have an 80-year-old that's still pretty sprightly and working out every day and has a long life ahead of her, I'm not going to say no to her mammograms, right? But if you have an 80-year-old that's already has a lot of ailments and different things, then we probably would. So it's, a personalized risk assessment. Everyone has their own personal history and they have all their assessment. While mammogram is still the standard of care and the main thing you should be getting yearly, in addition to the mammogram, your provider can send you for an ultrasound. There's the handheld, which is that limited one where you're looking specifically at a spot. And then there's the ABIS or the sonosine, and those are the ones that are like a big movie picture. There's MRIs, and then thermography, not one that we necessarily recommend, but it's on there. A quick overview of biopsies in case you ever have to have one. Basically, how we determine what biopsy you're getting is how did we see this mass or whatever on imaging? Did we see it by ultrasound? If we can see it by ultrasound, we're going to biopsy by ultrasound. If we can only see it by mammogram, say it's breast calcifications, then we're going to biopsy by mammogram. If we can only see it by MRI, we're going to biopsy by MRI. The least invasive is ultrasound, so we always try to do that one. And then excisional biopsy is kind of the last end all. If for whatever reason it's super close to the nipple or the biopsy result didn't get everything, then we do an excisional biopsy. Because what we have to remember is that most of the biopsies we do are needle biopsies. So they're only getting a really, really tiny amount of what we're looking at. So while this paper, we're looking at this screen that says biopsies, it's white, black, and orange, right? When we do a needle biopsy, we might put it right at the U in ultrasound and only get black. So you're only getting a tiny, tiny picture. And so that's why sometimes excisional biopsy gets recommended, because maybe we didn't get all of the picture or it doesn't make sense. Here are the screening recommendations. So ASBRS is the American Society of Breast Surgeons. So their recommendation is women under the age of 25 should undergo formal risk assessment. What that means is basically that every woman under 25 should talk to their provider about their family history, if they've ever had breast cysts, if they've ever had fibroadenomas, if they've had children, birth control, all that kind of stuff, and get their own personal risk score so that we know, okay, should we be starting you early or should you wait? The average risk of breast cancer should initiate yearly screening at age 40. That's kind of the norm. Women in higher risk should undergo, and that's what we were talking about before, you always have your mammogram, but then you're offered other supplemental imaging like an MRI. What they say is screening mammogram should cease when life expectancy is less than 10 years, and that gives you like a point. What we kind of do in our clinic is just kind of gauge the person and what they want. Here's risk assessment. So this is kind of going more into that high risk. It should be around the age 25 to 30, and they're, starting to discuss what's your family history? How much at risk are you to developing breast cancer? Other things that put you at higher risk is one, it's the family history, it's genetic testing. Two, it's if they have a prior history of any kind of atypia. So atypical hyperplasia or lobular carcinoma in situ. Or if they have any prior history of chest or mantle radiation therapy between the ages of 10 and 30. So if they've had, chemo or radiation in the past, and the radiation was to their chest, then they are also at higher risk. Anyone, same thing, age 30 or above, assess the risk. Now, really, really quickly, for high-risk patients, there's something called a Tyrer-Cuzick model. Basically, your Tyrer-Cuzick model is something that is personalized to you, and it says whether or not, like, if you have whatever increases or decreases your chance of getting breast cancer. So we know the different things, right? So we know family history increases, having children before 30 decreases, breastfeeding decreases, going on hormone replacement increases. Kind of, that's a weird one. But it is a question they ask. Your density increases. So there are different things. And we use this model to basically work with our patients to find out how at risk are you. It gives you a number, and if you're over 20%, you are considered high risk. If you're under 20%, then you're an average. This is a little bit of genetic testing in general. The main point to take from this is genetic testing is new. It's a new medicine, right? And they're always constantly learning and evolving and finding new things. So much so that if people did genetic testing before 2013, which is not that long ago, they actually are being asked to retest, because we know that before 2013, they only tested for BRCA1 and 2. And they didn't actually test for all the variants either. So after 2013, they started testing for full panel, and that includes PALB and CHEK and ATM and other different genetic mutations that can put you at higher risk for breast cancer. So if you or a family member ever did genetic testing before the year 2013, it's usually a good idea to check back in with whoever did your testing, and you would retest and do a full panel. Same with anyone that's done 23andMe or any of the over-the-counter genetic tests and it came back positive, and they still have a strong family history of cancer, then we'd say meet with a genetic counselor and have them actually do the full panel. Because we've actually seen false positives with 23andMe. So you could say, oh, I'm positive on this in 23andMe, but you do a full panel and it's not. For those that qualify for genetic testing, there's something called the NCCN guidelines. And these are kind of the couple things that usually you have to qualify. You have a known relative with a mutation like BRCA1 or 2, that qualifies you. You have a strong family with first or second degree relative under 45 years old, or they had ovarian cancer. So if, say, your aunt was 30, then you'd qualify, but not if she's 65. Or your mom was 36, you'd qualify. You have a strong history with 2 first degree, second degree, or third degree blood relatives with breast cancer. Even if you don't qualify under NCCN guidelines, genetic testing is not what it used to be. It used to be like $5,000. Now it can run you like $250, even if you don't do insurance. So if it does, you don't qualify, which a lot of people sometimes don't do because they have one, first degree relative, and it kind of gets tricky. It's really not that much money. These are the normal risk factors. I kind of went over to them, race, previous radiation to your chest, age over 55. The median age for cancer is 62, or what we see the most. Family history, gender, women. Men do get breast cancer. We do see it, but it's still about less than 1%. Genetic mutation, high risk lesions. That's that atypical that I was talking about. Early menstruation before the age of 12, late menopause after 55, giving birth after the age of 30, breastfeeding decreases, so it actually helps you, the number of births, and then we kind of put in here this breast implant associated large cell lymphoma, but that is very specific, and that is a very specific type of implant that was made way before, and they don't do those anymore. And even if you have those gummy ones, and they're allergen gummy ones, we actually don't have you remove them unless you have symptoms. And the symptoms that you would present with is something called a seroma. So you'd have a big pocket of fluid that would present itself, and then we'd test that, and then it would come back as this. But if you have them, you should have gotten a letter from your plastic surgeon, just kind of saying, hey, you have these, let's watch out for it. But it's not something that we actually are preventively taking out or anything like that. If you were to get them, like were to get this, then we take out the implants and you're usually fine. And then the last thing is not having kids. This is just a picture of your breast, just to kind of help you understand a little bit. I'm not going to touch too much into cancer, but basically you have your ducts and your lobulars. Those are where breast milk is made. A lot of cancer starts right there in the duct. When it's in the duct, it's called ductal carcinoma in situ. And I've said that a couple of times now. So it's in situ, it's encapsulated in the duct, right? And that we find by breast calcifications on your mammogram. When it leaves the duct and goes into your breast tissue, that's called invasive ductal carcinoma. I hate the word invasive because it sounds like it's all throughout your body. It is not. It is just in your breast tissue, right? Your breasts are not vital organs, so it can't hurt you, right? So that's kind of a very, very quick piece of the puzzle for that. Just another picture, like I was saying, right? It starts in your ducts, and that's ductal carcinoma in situ, and there's a little picture of it. When it leaves the ducts and goes into your breast tissue, invasive ductal carcinoma. These are kind of the main cancers, as you can see. Invasive ductal carcinoma takes up about 50 to 70% of the patients that we see. And these are the different stages. That's another question I always get asked when I do diagnose breast cancer. What are the stages? What stage am I in, right? So when it's in the duct, that's usually like stage 1, stage 0. I say that because it's a little bit controversial, DCIS. Some clinics think that, and I'll go back to this picture to kind of explain it. Our clinic treats DCIS like stage 1. It's in the duct, right? We know at some point it's going to move from the duct to the breast tissue. We don't know when, but we know at some point. So we treat it like stage 1, and we, surgically remove it, do everything we need to do. There is some research out there, and then there's other clinics out there that actually will treat it like a high-risk lesion, and they will leave it. Why? Because of that time frame. We don't know. For some people, it could be years before it moves from the duct to the breast tissue. But for some people, it can be months. So instead of surgically removing it, they actually just kind of wait and watch and have you follow it. So that's why there's this kind of like, oh, stage Stage 0 is stage 1 because there is a little controversy with it. And then stage 2, and stage 1 is also invasive ductal, where it's in the breast tissue still. This picture's weird. Stage 2 is when it goes in. Yes, okay. Stage 2 is when it goes into the lymph nodes, right? Lymph nodes are almost like the door to the rest of your body. If it doesn't go through the door, it can't get to the rest of the body. Stage 3 and 4 is when it's in the rest of the body. Excellent. So it's always important to have an annual clinical breast exam. Make sure your provider is taking your concerns seriously, and they can always order diagnostic imaging to investigate further. If you feel something and your imaging comes back negative and you still feel really uncertain, then you can always be referred to a breast specialist. Cancer feels like your knuckle or the pit of an olive. So it's hard, it's firm, it's rough, it kind of feels like a mountain, it's painless, and it'll always be fixed to a point, right? So it's always fixed somewhere, right? So every time you feel there, you're gonna find it. When something moves around and it's smooth and symmetrical, then it's a good sign it's benign, but it's always something we want to check out. So what are you looking for? You know, there's a million things, you hear this all the time. Change in the shape of your breast, swelling, redness, darkening, warmth of your breast. Bilateral nipple discharge is something that should be evaluated, but most likely it's nothing. Even when you have one side nipple discharge and it's bloody, it usually means it's a benign thing rather than cancer. A rash, skin lesion, dimpling of your breast. Dimpling means there's almost like an indentation in your breast. Pain in your breast, but remember what I talked about before, is most breast pain is not cancer. It's usually hormonal or a cyst or a fibroadenoma, but always should be evaluated to find out. A sudden inversion of your nipple. So your nipple would actually go inside, and a lump or hardening of your breast. So these are a couple of different pictures. You see the redness, you see the swelling, one breast is bigger than the other. Pude orange is basically you get so swollen and your breast gets so hard that you see the pores. You can kind of see that here. There's a change to my breast, what should I do? And these are the different things that you can see. Feels a mass, nipple discharge, male breasts have a, if a male feels a mass, breast pain, skin conditioning changes. In the past, you'd go see your primary care, your OB, you'd get referred to a mammogram. You'd have an abnormal finding. 2 weeks later, you'd have additional imaging. Another 2 weeks later, you'd do a breast biopsy. Another 2 weeks later, you'd get the diagnosis. And so there was a lot of research done on this, and they were actually finding out that from initial recognition of a lump to a final diagnosis of benign or cancer, the average number of days was 16. So that's a long time, right? And for every single woman that feels anything in their breast, no matter what, their mind goes straight to breast cancer. So that is just anxiety the whole time. And 16 days is a long time. And like I said before, most of the time it's benign. 80% of the time it's benign. So you're just in this really long period of anxiety for nothing. Among women aged 65 to 84 years old, the mean duration, so the average amount of time from an abnormal mammogram to a biopsy was 33 days. From someone telling you, hey, something's wrong here, you need to biopsy it, to actually getting that biopsy was a month. That's crazy. And then the average overall time from the mammogram to treatment was 65 days with an average of 40 days. So while awaiting diagnosis, I kind of touched on this, patients experience absenteeism and presenteeism, right? You're so anxious, you're not living your life. Your mind is in the clouds. You are already thinking about your future and the treatments you have to have and everything that comes with it, because you're just waiting to get that answer. So where I work, the Breast Health Clinic, we've tried to make this a lot faster. So instead of all the different things, you actually just come, you get refer, you can self-refer, you don't need a referral. And you get a consultation and a clinical breast exam. And we can do usually same day imaging, if not the next, and expedited biopsies. So then we have to wait the, 3 to 4 days for pathology, and then you get a diagnosis. So our average is now at about, when someone feels something, usually we can get, the imaging same day, if not the next. If there's no biopsy, it's usually resolved in a day or two. If there's a biopsy, it's usually resolved in about 3 to 4 days. Our fastest that we've ever had, someone get into treatment has been, I've seen them on a Monday, they've got a biopsy the same day, and they're seeing Dr. Grumley or Dr. Fancher by a Thursday. So that's pretty good. So it decreases that waiting period. It decreases that anxiety. And for the most part, 80% of the time, it's benign. So it decreases, that long period of time of waiting. And then, I see all the people at the front end, but if it's not benign, then you get referred over to our multidisciplinary clinic, like I was talking about, Dr. Jamie Grumley and Dr. Crystal Fancher, and all our radiation oncology and medical oncology, Dr. Parvin Petty, and you get the care that you need. So what we know is faster diagnosis equals faster treatment. This is how you make an appointment. It's called the Breast Health Clinic. You can call. And then any questions. So we're all done. So any questions, we're going to open up to that.
Perfect. Thank you so much, Tara. Yeah, that was such a great presentation. So informative. So we did have a few questions that came through. Let me go ahead and ask. One of the questions was, is the dye in the MRI contrast safe? How often can an MRI be safely done?
Yes. So the dye in the MRI is safe. It is gadolinium. Yeah, I can never say that word right, but it is not the same dye used in a CT contrast, which is iodine. So a lot of people have allergic reactions to iodine. And a lot of people that have allergies to shellfish have allergic reactions to iodine. So a lot of people will have a CT scan and they'll say, oh, I had an allergic reaction, I can't get an MRI. But the contrast in the MRI is actually a lot less allergic reactions. It's very minimal and it's very safe. Usually we have them just do one once a year, but it can depend. I mean, the normal is if you're high risk, then you're getting one every 6 months. But the idea is you're getting a mammogram and an MRI every year. But we like to split it up in that 6 months to make it easier. Sometimes though, you can get that MRI and then they want to look at something again in 6 months on MRI. So you might get 2 a year, but that's usually the max and it's perfectly safe. It's a big magnet. The contrast is safe. It goes through your kidneys. So unless you have any like chronic kidney disorder or anything like that, it's perfectly safe. They've done a lot of research on MS patients on this, who get MRIs frequently. They get them, a lot more, and they notice that there's no residue or it doesn't stay in the body as long.
Okay, that sounds good. Another question was, what are some screening recommendations for those who have had a unilateral or a bilateral mastectomy? Okay,
so bilateral mastectomy, that takes away the mammogram. Right, because there's not really, they do leave breast tissue. There is breast tissue because you have to leave vascularity, but there's just not enough to do a mammogram unless like we're really looking at something, but screening wise, it doesn't make sense. So bilateral, there isn't a mammogram. The recommendation is always to continue having your clinical breast exam. And then if they ever kind of feel anything, then you would do ultrasound or MRI. If you have implants, then it's always good to be getting MRIs a couple years to check the integrity of your implants, because that's the best way to check them. But once you get a bilateral mastectomy, then there's no really like screening imaging anymore, other than your clinical breast exam is still very important to do every year. And then they can use the other two modalities, ultrasound and MRI, as needed. A unilateral mammogram, or sorry, mastectomy, They wouldn't do a mammogram on the mastectomy side, but they would do a mammogram on the non-mastectomy side. So you'd still get your mammogram every year
Okay.
on that side.
Somebody asked how many ultrasounds after they've been diagnosed, they've had a lumpectomy, and then radiation are usually recommended.
I'm sorry, I didn't hear you.
Like how many ultrasounds are usually recommended after they've been diagnosed, they've had a lumpectomy, and they've completed radiation?
That just depends on the provider and on the patient. You know, you still want to do your mammograms, and then it depends on like who you are. There's no real number to it. Like a lot of the times they'll do a mammogram and do an ultrasound right after.
Okay. Somebody asked, what is the standard mammogram schedule after lumpectomy and radiation? I think that was asked already. Did you answer
Well,
that?
if it's a lumpectomy, then you're going back to your normal mammograms. At our clinic, we see them every 6 months for the first 2 years, and you're doing your annual mammogram. And then after that, it's annually. But you're still doing your annual mammograms after a lumpectomy.
Okay. Are there any specific screening protocols post-surgery, like post-lumpectomy?
Same thing. So post lumpectomy, you would still be doing your annual mammograms.
Okay.
The only reason post lumpectomy or post cancer that we'd add an MRI is if your cancer was found by MRI.
Okay.
That makes sense.
Yeah. Somebody asked, it's extremely difficult for them to get on the table to lie down for an MRI. Are there any alternatives that are just as well?
I mean, sometimes you can work with your provider and you can like, instead of if the MRI is not something you can handle or do, there's not really, unfortunately, alternatives to it, because unfortunately with the MRI for the breast, it has to be contrast and it has to be closed. But, you know, depending on it, you can also do mammogram 6 months later, ultrasound 6 months later, mammogram. So people can kind of work with the schedule. It's not set in stone or anything like that.
Okay. Somebody asked, if you have dense breast, why is it not automatic to do an ultrasound or an MRI?
Usually it should be, but it should be. If you have dense breast, you should be getting an ultrasound after, especially an ultrasound. I totally agree with that. If you have dense breast, then you do at least for my patients, if you have dense breast, I always do a mammogram and an ultrasound after. But it's educating your provider. It's educating who's sending you for this, right? They have to put the orders in it. MRI wise, I would love to send everyone with a dense breast for MRI. That one, unfortunately, is an insurance thing. A lot of insurances won't cover it. That's the end of it. If someone wants to play out of pocket for it, happy to send them for it. It's just that insurances go off different guidelines, and that's just one that some insurances cover and some don't.
Okay. And then I'm not sure if this person is asking specifically for your clinic, but does somebody need to be referred to the breast clinic? No.
Nope, not unless they have an HMO. If they're a PPO, then they can just self-refer.
Self-refer. Okay. Sorry, I'm just going through some of these because I feel like we might have answered them. Does routine after lumpectomy mean 2D mammogram?
A routine? No, I would always recommend a 3D mammogram.
Okay.
So 2D mammogram is ones we like used to do, and some imaging centers still do them. Most imaging centers in the LA area do 3D, so you don't have to really worry about it. But recently I did find one that's still doing 2D. So that's the only reason I kind of put it out there, is just make sure you're having a 3D.
Okay. Okay. Somebody did ask, what are the pros or cons for using other body tissue versus implants after mastectomy? If you happen to know.
There's not, I don't know for sure. There's not really pros or cons to it. It's usually just kind of like the look and the feel for it. You still can't do the, like we don't offer a mammogram for it because it's still, you know, your breast tissue is gone. But I mean, it's more like a look and feel and how you feel and stuff, but it would still be considered a mastectomy because the tissue is gone. And so we don't necessarily do the mammograms with them.
Okay. And then we did have somebody ask, I've had a couple questions actually come through regarding like a baseline mammogram. So they said after lumpectomy and radiation, should you get a baseline mammogram to be able to do a comparison for annual ones?
After, we tend not to do it right after, because right after you've done a lumpectomy or radiation, you actually have a lot of breast changes. So we usually wait about 6 months before we do your mammogram, and that would be your like baseline, and then you'd start your annual. But right after, there's just too many changes, too much inflammation kind of going on, so it wouldn't give us like the best one. But usually we wait about 6 months and then we would do one.
Okay. I think we have time for one more question, if that's okay. Somebody asked, which I think you already answered. Did you say you only accept PPOs are accepted, but not HMOs?
No, we do accept HMOs. You just have to have a referral with HMOs, whereas PPOs, you don't need a referral.
Got it. Perfect.
And I do just want to mention, there's one question that I disagree with ultrasound not used. That's not what I meant at all. Ultrasound is used for diagnosis. Basically, yeah, it can also not be seen. So if you have something that you're looking for, you have a mass, then yeah, we would use mammogram, ultrasound, MRI, whatever imaging we can find for a diagnosis. All I meant is a lot of people try to get rid of the mammogram. You know, that's really, really kind of one of the main things I hear when people come in is, I don't want to do the mammogram, it hurts, it's radiation. So all I meant by that is that, you know, mammogram is kind of that standard of care that shouldn't be taken away, but the others come with it. So there's always a reason to add in ultrasound. Ultrasound is one of my favorite things that I use a lot because it does tell you, what does this look like? Do I need to biopsy, whatnot? So agreed that it's very helpful for diagnosis. I never meant that. That's absolutely, I agree with you, Raquel.
Awesome. Okay, thank you so much for that clarity. I know we weren't able to get to everybody's questions, but if people wanted to send you questions, is there an email address or should they go through us and then we can filter that way, whichever way?
Sure, I can write my email in the chat.
Perfect. And then while Tara's doing that, oh, there it is. Perfect. Oh, let me actually go ahead and share it with everybody. I think it's not.
Oh, it's with you.
Yeah, but it's okay. So there is Tara's email address. If you guys have any more questions that she can answer, you can go ahead and send her email there at tara.kays@providence.org. If you have any questions for us, you can go ahead and send us a message as well at info@cancersupportla.org. I want to thank Tara again so much for today, for the presentation. It's such a great, informative talk, something that I know is very beneficial for our community. And thank you everybody for joining us today. I hope you all have a great day. Thank you. Bye.